Welcome to this lecture on oral surgical pathology. We're going to talk in this particular section about some of the basic histology, anatomy, and nomenclature. We'll talk a little bit about some of the unusual infectious and inflammatory lesions that are encountered here. We won't get too much into the squamous preneoplastic lesions in this lecture, but we will begin to talk about some of the non-neoplastic lesions or semi-neoplastic lesions, and a few of the non-epithelial tumors that we will talk about. Oral pathology represents an interesting coincidence of many fields of study. We have the head and neck pathology, of course, the squamous and salivary gland lesions, but we also encounter bone and dental lesions that are unique to this area, as well as encountering some of the skin diseases that can affect the mucous membranes, and occasionally even some other areas of pathology as well. There are some key terms to understand when thinking about the oral cavity, and that is that things tend to be fairly similar grossly. There tend to be white lesions and there tend to be red lesions. And these have fairly broad differentials. Their presence of a mass or a diffuse type of lesion can be quite different if it's red or white. And we'll be looking at some of these issues as we talk. So these are some of the lesions that present as white lesions and tend to be rather diffuse rather than discrete masses. The white sponge nevus, the warty dyskeratoma, and Darier's disease, which have identical histology, and hereditary benign intraepithelial dyskeratosis. Here's the white sponge nevus. As you see, it is an epithelial-based nevus. It is not a submucosal or melanocytic type of nevus that might be more typically associated with this term. It tends to have hyperplastic squamous mucosa, slightly thickened, which is quite clear. There's a lot of perinuclear clearing. Because it's thick, that is what gives it its white appearance. It is not highly vascular. Now, it can also have associated candida, which can be an infectious complication of that, and that can be treated. But the hallmark features are this perinuclear clearing and the presence of scattered intraepithelial associated dyskeratotic cells, as you see here. It usually appears on the cheek in the first few decades of life. This is a very rare autosomal dominant disorder which has these mutations and is associated with this kind of slight hyperparakeratosis, spongy appearance, and so forth that we just saw on those images. The hereditary benign intraepithelial dyskeratosis has somewhat of a similar appearance. It also is somewhat white, not very vascular. It's very hyperplastic, but you see it has more hyperkeratosis and it has more abundant dyskeratosis right within this acanthodic appearing material. So it lacks the spongy appearance, the perinuclear clearing that you would see with a white sponge nevus, and again is a fairly diffuse process. The warty dyskeratoma, or Darier's disease, has focal areas of wart-like change that can be fairly broad-based. This can be associated with a mutation as well, and these very umbilicated, crater-like area with both needle-shaped and rounded dyskeratotic cells are fairly typical. Here's one of these little core ronde that you would expect to see in Darier's disease. Now, when we talk about nodular lesions, there is a much broader differential. Many of these are similar, are uncommon, but a few are fairly common. The histology is fairly obvious in some of them and less obvious in others. So we'll just touch on some of the high points here. The Fordyce granule is essentially a hyperplastic sebaceous gland. Here you see this gross appearance, which is a slightly nodular, pale yellowish, still somewhat diffuse type of process rather than a discrete nodule. And these can be present either as just a single area, or a more nodular area, or a more diffuse hyperplastic area. It's all the same process that we would expect. Gingival fibromatosis is an unusual lesion. Sometimes it's associated with syndromes, some inheritable syndromes, and particularly patients who are on anticonvulsant agents, phenytoin and so forth, may aggravate this process where you get this hyperplasia right along the gum line of the gingiva. Now, in contrast to fibromatosis elsewhere, this does not tend to be hypercellular and has somewhat of a different histologic appearance, even though it has the same name. So it can be somewhat confusing, as many times oral pathology is. The naming conventions are not always the same as we use elsewhere. This is submucosal. You see here the keratinized or the squamous mucosa, and this very hyalinized, densely collagenized stroma that characterizes it. Another term which has a similar name but yet not a totally similar histology is the congenital granular cell tumor. This usually occurs early in life, usually noted within the first few weeks or months of life. And it has somewhat of a granular cytoplasm, hence the name. But in contrast to typical granular cell tumors that we'll see elsewhere later, this tumor is S100 negative. It is not quite the same histology, but it's a similar submucosal tumor. It does stain with CD68 and NSE, but not with S100. Lingual thyroid is another lesion that can be somewhat nodular. This is usually in adults, and as expected from the embryology, this usually presents as a midline mass in the circumvallate papillae posterior area, reminiscent of the thyroglossal duct. This is essentially a suprahyoid version of a thyroglossal duct type tissue remnant. Now, there are also chorostomas that can be seen in this area as nodular lesions. Those that are made primarily of bone tend to occur in the midline in young adults, whereas those that have primarily cartilage, usually a little bit more laterally in the tongue. These are presented interesting differential diagnosis, primarily one involving myositis ossificans, myoepithelioma with metaplasia, or other sorts of things. It is thought that sometimes these lesions are metaplastic, but the characteristic appearance of mature bone and cartilage with a reactive type stroma and this kind of location that we've talked about here would be characteristic of the choristoma. Now, in addition to thinking about nodular lesions, we need to think about cystic ones, as these also can be fairly common, and these are the ones that we will think about here. Again, the histology is not highly exciting, but recognizing the anatomy, the embryology, and some of the history here is important. A lymphoepithelial cyst is quite common, particularly in the Waldeyer ring tonsillar area. So the epiglottis, the tonsils, this type of area will present us with these dilated spaces filled with slightly keratinized material and surrounded by a dense lymphoid cuff, as you see here, much as a tonsillar type of tissue might be expected to have. How do we distinguish this from a dilated crypt? There really isn't too much difference. These do tend to have more watery and less inflamed material. They don't tend to have bacterial or actinomyces type contaminants in them. and so we would call them a lymphoepithelial cyst rather than just a dilated tonsillar crypt. Epidermoid and dermoid cysts also occur in this area and in different age groups. The difference between an epidermoid and a dermoid cyst is a significant one in the sense of histology, but not significant in the sense of behavior. Epidermoid cysts consist exclusively of squamous epithelium with keratinization, that you see here. No adnexal structures are present in the surrounding stroma. But with dermoid cysts, they do have adnexal structures. They may have hair, they often have sebaceous elements, and they may have other elements as well. So if you see adnexal structures, it's a dermoid cyst. If you don't see them, it's an epidermoid cyst. A unique additional cystic structure is this little cystic structure right in the midline anterior palate, the cyst of the incisive papillae, or a remnant of the nasopalatine duct that has become cystically dilated. These are interesting because of their location and the embryology involved, but histologically they're fairly boring. However, they can have low cuboidal epithelium and occasionally ciliated epithelium, as you see here in this lower image. Let me talk for a minute or two about the papillary lesions we see in the mouth. These are several very interesting lesions that we will see, and there are others, of course, the usual squamous papilloma and so forth. One is inflammatory papillary hyperplasia of the palate. Verruciform xanthoma is another, and the juvenile localized spongiotic gingival hyperplasia is a third. The names are much more complicated than the histology. Inflammatory papillary hyperplasia usually looks something like this. It occurs on the palate in adults and is often associated with dentures. It could be just called an inflamed squamous papilloma, but it is so diffuse that it is best called a papillary hyperplasia. Now sometimes there can be associated candidiasis in these that may account for the inflammation. It's probably related to the trauma and the reaction to having a denture in place that irritates the palate in this way and causes this reaction. The verruciform xanthoma, in contrast, here's a clinical picture, a somewhat plaque-like diffuse area here on the tongue, has a lot of appearances that look very warty, hence the name, verruciform. There's acanthosis, hyperplasia, and there's dense hyperkeratosis within these little crypt-like valleys between the rete. The thing that gets its name, however, is as we look at the stroma, there is a considerable amount of xanthomatous change in the stroma that here you can see very weakly stains with CD68 or CD163. And so if you see those cells, the xanthoma cells in the stroma, then you think verruciform xanthoma rather than verrucous or verrucous hyperplasia or a dysplasia. You do have to watch to make sure that you're not missing a preneoplastic lesion with this, but if you see the xanthoma cells, that should be sufficient warning that this is just a verruca-like lesion. The juvenile spongiotic hyperplasia has this type of a clinical appearance. It tends to appear here along the gingiva and tends to be a reactive lesion. It is a fairly young age of presentation, and it may be multifocal, as you see here, a little bit over here and some here. The histology is somewhat distinctive with this marked edematous change, hence this term, sponge-like appearance. So clear cytoplasm essentially is really the edema between the cells, and it has a little bit of a hyperplastic or verrucoid type of appearance. I'll comment also about hairy leukoplakia, which can also be a diffuse lesion. Here you see it along the tongue. This is highly predictive of HIV infection, but it can also be seen in organ transplant recipients. It's felt to be an EBV-related squamous hyperplasia that results in this very characteristic hyperkeratosis type of appearance that, as you see, is not highly vascularized and so appears as a white type of lesion. Now, it wouldn't be pathology if we weren't talking about HPV, and so there are a variety of appearances for HPV type of lesions that can range from something that looks like that juvenile verruciform hyperplasia, or things that look more diffusely of this sort. These would have the typical HPV type of morphology with collocyte changes, possibly some dysplasia, and so forth. So I won't go into the histology further, but just to point out that these also occur in the mouth.